excited to do this. Both Jimmy and I believe very much in the importance of collaboration with an end goal of improving patient care and safety. And so for this evening, we have two goals. One is to help equip everyone in the audience, whether it's in person or virtually, to help build a framework that you can then go back to your home institution and build a complex PCI program. As part of that also, another goal is to use tools and skill sets to make PCI safer and more efficacious in order to tackle more and more complex anatomy and make outcomes better. These are my disclosures. And so just briefly as an outline, again, for this evening, we're going to start out with something that you may not think of in terms of PCI, but in terms of understanding complex systems, which is what PCI really is. There's a science to that, and I think understanding that science is extremely important in understanding how to approach complex PCI. And so we'll talk about that briefly. And then we'll move into some of the more practical aspects of this, which are making the guide your ally. That's no longer just guide size and guide shape, but there are a number of tools now that also affect that aspect of PCI. I'll then turn things over to my partner, Dr. Kerrigan, who will do a very case-based deep dive into some anatomy that is pretty hostile, but is successfully treated by using tools and skill sets and philosophies. And then we'll wrap things up with some questions, and whether it's from the virtual audience or from our in-person audience here. So before you can go back to your home institution and build a PCI program, you have to get the nuts and bolts, your toolkit in place. And that's important for several reasons. Part of it is developing an efficient workflow. If you can put your complex PCI tools in one place, preferably if you have a large lab with multiple angio suites, you would have that on a roll-around cart. But you want to have your 7 and 8 French guides, your shortened guides, your dissection reentry tools, your microcatheters, specialty wires, all in one place. If you think about it, if you're sending your staff out, every couple of minutes to get equipment, that's 2, 3, 4, 5 minutes each time. If you are in the midst of a complex PCI that has 50 steps, you're adding a couple hours to your procedure. That wears on your staff, that wears on you as the operator, and just adds to fatigue and also increases the chance of failure in your procedure. The other thing to think about is make your staff your ally. Allow them to organize this the way they see fit. Our staff, I can tell you, has organized our wires both by tip load and alphabetically, and then gone back to tip load organization and back and forth. They do it because they're passionate about what they do, and it also makes their life easier and more efficient. The other thing you want to notice in this picture is the red cart on the left. This is a high-risk business, and you want to be prepared for emergencies. And so the red cart is our emergency cart, and that includes coils, pericardiocentesis trays. In some cases, covered stents are also housed in a cart like this. And so as you approach building your program, you want to think about the entire spectrum of this type of work and think about the emergencies and make your care for those situations more efficient. So let's talk a little bit about procedural planning. Again, as I mentioned earlier, there is a science to this. And cardiovascular interventions are a complex business. They're complex cognitively. They require extensive understanding of physiology, pathophysiology. You have to collate a tremendous amount of data. You have to do that in real time, and then you have to use that data to make rapid decisions. That is a complex system. And so giving your complex PCI a structure allows you to grow in the space and to grow your skill set and your team's skill set to increase the ability to tackle more complex anatomy. I think this can be summarized by a very famous aphorism by someone who's not a cardiologist, who's a French chemist and microbiologist. And of course, this is Louis Pasteur, who said chance favors the prepared mind. And that is an extremely important thing to keep in mind as you build out your complex PCI program. So let's get into the science of PCI decision-making a little bit. This was really nicely outlined by a German cardiologist named Peter Lanzer. And so he broke down PCI, and in our case, complex PCI, into 5 parts. The first part is what he called initialization. Initialization means you are in the planning phase. You are developing the strategy based on your understanding of the patient's profile, based on the lesion profile, based on your shared decision-making discussion with the patient in terms of your goals. And you're trying to incorporate all that into developing your strategy for the MIC. The MIC is your main interventional cycle. That's actually kind of the work of PCI. The work of PCI, in his philosophy, the MIC involves 2 parts. One is the angiography, interpreting the angiogram, and then acting on that angiogram to do what he calls an interventional action. For a direct stent, that could be 2 steps. Wire the lesion, place your stent, and deploy it. For a lot of what we do, that may involve 50 or more steps. Understanding the science of PCI and complex systems allows you to strategize in a way that is more sophisticated than what we traditionally do, which is kind of off the cuff in real time. So after you go through your MIC, then comes what he calls termination, which is getting the gear out and closing the access. After that is the aftercare. And so the aftercare involves the in-hospital care up to discharge and then follow-up, which may be 2 to 4 weeks later, 6 months later, and a year later, kind of the standard cycle around that. So let's talk a bit about strategy design. So this is more of a deep dive into that initialization phase. And so what you're going to do is analyze your patient-related factors, their frailty, their kidney function, their vascular access. That's an extremely important part that we usually will do in that initial encounter, whether it's in the office or in the holding room of the cath lab. You're then going to analyze your target lesion-related factors. This would relate to calcification, nature of the plaque, tortuosity, etc. You really should think of this as very much like sailing. And so, your patient-related factors would be the wind forecast, your weather forecast, the things that you don't have a lot of control over. The lesion may be your planning around what type of harbor are you going to sail into. Is it a harbor that has a very narrow inlet and rocks on either side, and you've got to really worry about your approach to that harbor? And so as you think about this is very much like planning a high-risk endeavor like a long sailing course or adventure. After you've done your patient assessment and your lesion assessment, then you get to the comprehensive risk assessment. This is where you are going to collate all of this information and also collate your discussion with the patient as you move into your defining the aim, which really nowadays should involve a shared decision-making with the patient. You may have a patient who would say, I really want to avoid risk, which may change your approach to a particular lesion. You may be a little bit less aggressive and a little bit less complete, even though completeness is a big deal nowadays, but you may be a little bit less complete in a patient who says, I really want to avoid risk and I don't want a high-risk atherectomy, for example, of a particular lesion. And then after you've done all that, then you still have to plan your interventions. You have to plan the MIC and your sequence of interventions, which you may spend half an hour staring at an angiogram trying to accomplish that goal. A couple things about risk that I think are important. And if, in this slide, it reminds us that we are a big part of that risk as the operator. And that risk, from our standpoint, may involve our skill set, our knowledge base, and deficiencies in those 2 areas. And that's where the CTO community, the complex PCI community, has really developed a less and less ego-driven approach. It's not about me, it's about the patient. If I have a skill set that can accomplish the goal safely, then I really should get help, whether it's with a proctor or giving that case to someone else. I think one other layer of risk that I want to talk about is being very sophisticated in terms of the vocabulary. So there are two types of risk we need to think about in terms of PCI. One is latent risk. That's the patient and the lesion. You can't control that risk. The other risk, which is important for us, again, to keep in mind, is the actional risk. That is us. That's the operator. And that involves our skill set, our knowledge base, and then also something called the optimum choice risk, which includes kind of that old concept of the enemy of good is better risk. So I just want to go through an example of planning a procedure. This is a patient of ours that we did not too long ago. Obviously, a CTO of the RCA, you can see there are two guides in. You can see that the guides are, the less supportive guides, and that's for a reason. This patient had a very narrow aorta, and getting more supportive guides to fit was actually very difficult. And so as you put together your patient-related factors, some of that has to be done real time, so you can only plan so much. But this was a patient who was 44, very precocious onset of CAD, had bypass in his mid-30s. Diabetic with typically diabetic vessels and heavily diseased distal runoff. He had normal renal function, fortunately, even as a diabetic, but he was quite obese. His BMI was 48. So as you go through your procedure planning, patient-related factors here that are important are the patient's size, has normal renal function, very diseased distal vessels. And we'll get to that again here in a second. So as you move on, then you're going to move into the target lesion-related factors. You'll probably be able to see here there are two stents in this vessel, proximal and mid. There is a little bit of trickle of contrast through the more distal stent. The proximal stent clearly has a channel through it. And so as you work through your planning, you're going to take all these factors into account. You're also going to take into account that your landing zone distally is quite poor, again, a very diabetic-looking vessel. And this island of contrast that you see kind of in the middle stent, the mid-vessel stent, you may actually be dealing with a relatively short occlusion here, which wasn't appreciated so well with single vessel angiography. Dual vessel or dual angiography makes an incredible difference in your understanding of some of this anatomy. So as we figure out our risks and do our comprehensive assessment here, our latent risks are the patient's obese. You may want to think about biradial access. You'll notice here that this case was being done biradial. He's a diabetic. He had very poor runoff vessels, so you may not stent in the initial encounter. You may treat this vessel, repressurize it, then actually walk away and let this vessel kind of declare itself in terms of what the distal bed is going to look like. And then as you also think about this is in stent. You may need to consider future brachytherapy to be able to give this young patient a durable and optimal result. Again, and as we define the aim, again, in a young patient, we want durability. And this was a patient with intractable angina despite multiple anti-anginal drugs. And so ultimately the aim here is to give angina relief. I cannot emphasize enough that a multidisciplinary heart team is extremely important as you tackle this anatomy. We've been blessed with a very collaborative team that meets every Wednesday morning to review cases and get everyone's thoughts. This replicates what the heart team from the structural space did and did very well. But it's really important now throughout the world that we develop these same heart teams that sit down in person, preferably, or virtually, to discuss these cases. This can really enhance the care of complex patients and should really meet, as I said, weekly to have sufficient timeliness for these patients. There are some challenges, though. This can lead to some inertia in decision-making. We'll sometimes sit in a room and really pause, and there'll be silence for a while trying to figure out what do we do, or no one wants to kind of tackle this complex case, and we eventually come to a consensus. But there can be inertia that you have to be aware of. The other thing to be aware of is this requires a lot of effort. We're fortunate to have an excellent coordinator who helps organize the meeting and also provide feedback at the end of the meeting to everyone so that they understand what the decision was made for their patient. There was a nice paper written on this a couple years ago out of the Boston groups. Actually, one of my former fellows was the lead author on this paper, but it really nicely described how to do this. And actually in that paper, they provide their template for collating the data for these discussions. I would really encourage you to get this paper. First author, Mike Young, in the Journal of American Heart Association. So one other thing on building what we call an advanced coronary therapeutics program or team is the basics of ACT. A, in this case, being the administration. You have to have buy-in from your administration. They need to allow you to double scrub with a partner that you can collaborate with. You need to make this less financially as a disincentive. And you also need to make sure that you have buy-in from a inventory and logistics standpoint. The C is colleagues, and colleagues here would be the cardiac surgeons. We're fortunate to have cardiac surgeons who are very skilled at mid-cab and minimally invasive bypass. That makes a world of difference in how you approach some of these patients. And also your cath lab staff and your cath lab leadership are a huge part of this collegial team. And then T is team. Again, you need to have buy-in from your cath lab staff and a dedicated CTO team, preferably. So that kind of closes out part one. Just some take-home messages here are a few things. One is understanding the science of PCI and complex systems is really important to make a good complex PCI program a great complex PCI program. I would really encourage novice operators to either find a senior partner or, if you have to, go outside your institution to find a proctor who will help you through some of these cases, especially early on as you build your program. Double scrubbing, I think, is extremely important. These are long cases. Mental fatigue, physical fatigue really does set in. And so that alleviates some of that risk to you and the patient. Review the films. If you don't have a senior partner to review the films with, find a rep. A lot of these reps who are dedicated to the space have seen thousands of cases, and they're an incredible resource. And last thing is building an ACT or advanced coronary therapeutics program is really multidisciplinary. So you need to find a surgeon who's thoughtful, who is collaborative, who can work with you in this space. So I'll move on now to part two. I want to talk a little bit about guide catheters and what this means in modern parlance from a complex PCI standpoint. As I mentioned earlier, it's not just about the guide shape and the guide size anymore. So aspects of guide support, as we mentioned, size and shape, but also guide extension catheters. Supportive guide wires are really in this realm nowadays, and also balloon anchoring techniques to add just one other trick in the tool bag to get adequate guide support. I'm going to start actually with guide size. Defaulting to the use of a 7 French system for complex PCI from the radial approach for us has really become standard of care. We do the majority of our cases radial and do that with a 7 French system. It adds support, it adds options when things don't go well, it adds options in terms of how you approach atherectomy. A 7 French guide has an outer diameter of 2.8 millimeters essentially, and actually a very nice paper from about 20 years ago from Arnold Saito and team show that about 50% of people have a radial artery that's 3 millimeters or larger. That includes men and women. And 75% of men have a radial artery that is at least 2.8 millimeters or larger. The majority of patients can be treated radially and with a 7 French system. There's also the option to use long sheaths from the radial approach. So we will often use the R2P sheath, which is a 6 French system. You don't have a 7 French option there, but it does add another layer of support that can be in your tool bag. So let's look at a case that kind of illustrates guide support. This is a farmer who's referred to me because he had a atretic lima and was having terrible angina. He couldn't get around his property. He couldn't do what he needed to for his cattle. He was a cattle farmer. And so he presented with this anatomy, pretty hostile, very ectatic, heavily diseased. I was quite worried here as I did my risk assessment for the risk of perforation. As you can see, it's a calcified vessel, and this was going to require atherectomy to get the job done. You'll notice this is the guide. It's radial. It's a 7 French guide. So I've set myself up to have enough support to get an atherectomy burr through there and also to bail out should I perforate this vessel. Here's atherectomy. It took about 5 pecks at this, 5 separate rotational atherectomy runs just to get through. This is the final run. I don't think I could have done that with a 6 French guide. I think the guide support would have been inadequate. But with that level of guide support, we were able to get through and polish up this vessel in order to image guided stent this and get a pretty nice result. The patient still has had a durable result about 1.5 years later and is doing very well. Again, guide support from a 7 French system radial, I think, is an important tool to keep in your tool bag. What about guide extensions? Guide extensions, I think now, for us, are a basic part of our armamentarium. Our staff will oftentimes just ask, do you want the assembly? What they mean by that is, do you want the 7 French trap liner, a microcatheter, and your workhorse wire all set up together, ready to go? And oftentimes the answer is yes. We just want to go ahead and go in with that system and start off ready to succeed. Now, I would encourage you to practice different approaches to using the guide catheter, the guide extension. We use several techniques kind of interchangeably depending on the scenario. One technique to get your guide catheter or guide extension delivered is BAT, B-A-T, which is balloon-assisted tracking. What you do there is you'll inflate usually a 2 millimeter balloon, kind of halfway in your extension, halfway out, and use the exposed balloon as a bumper to try to penetrate through and get down the vessel. Another technique would be the inchworm technique. I prefer that. I think Jimmy really likes to use BAT, but I prefer the inchworm technique, which means you'll use a relatively long balloon just outside your guide extension, inflate, and then as you deflate, work your guide extension over the balloon shaft. I find that works very well as a means of delivering your guide extension way down the vessel. A third technique is anchoring. So you'll inflate a balloon distally, usually just proximal to or in sometimes the lesion, and advance your guide catheter as that balloon is inflated, giving you additional support. And then one other thing to think about is unsheathing. You may not think of that as a technique, but catheter perhaps beyond the disease segment of interest, and then unsheath your stent. Oftentimes getting the stent is the hardest part of the procedure, and unsheathing a guide extension is a nice way to get that delivery to happen. As I mentioned, guide extensions are an essential tool for us, and this is an example of guide liner assisted reverse cart. And so this is a patient with a RCA CTO. It's an interesting anatomy because you'll notice downstream there is a very long bridging collateral. If you just took a quick look at this, you might think, oh, there's a channel all the way through this vessel. But in fact, it's a bridging collateral from the proximal cap to the distal cap that is just at the distal bifurcation. In this situation, we did try a antegrade approach, but that was not successful and ended up having to go retrograde. And once we got some antegrade gear started and delivered a guide extension about midway down the vessel, we were able to get a retrograde wire into the guide extension after essentially ballooning antegrade and doing a reverse cart, which means that you have wires in 2 subintimal spaces. You balloon antegrade to try to connect the 2 spaces and then wire into your antegrade guide and essentially connect true and true. And after doing that connection, we were able to balloon and stent and get this final result. So in terms of guide extensions, you really want to practice some of these techniques in terms of balloon assisted tracking, inchworm, because you never know when that's going to come up as a required skill set in one of your procedures. And if you do CTO, guideliner assisted reverse card is an essential tool in the toolkit. So I would consider supportive wires as part of your guide support strategy. I have to say, after moving to my current institution, I have become a fan of the wiggle wire. And that's something I've inherited from my partner. And again, collaboration, cross-pollination of techniques is an extremely important part of building out your skill set and building out this space. So in terms of the wiggle wire, it's a very soft wire with a 0.5 gram tip. It has these 3 millimeter oscillations, between 6 and 12 centimeters from the tip. And what that provides you is, one, it limits wire bias. It also helps anchor the wire distally in the vessel and giving you additional support. If you don't have the wiggle wire, the Grand Slam, the Ironman, and the All-Star wires are other options as far as very stiff wires to give you additional support. And then the last thing to think about in terms of guide support would be balloon anchoring. Balloon anchoring is a technique where you will put a safe, soft wire in a branch, somewhere relatively proximal in the vessel. You will place a balloon in that branch over that wire and inflate it to give you an additional level of friction to anchor your guide and support your guide. Sometimes delivering gear distally is benefited by using that technique. And so if you develop these toolkits, 7 French from the radial, supportive wires, guide extensions and proper delivery of guide extensions and balloon anchoring, you've really put all the tools in the tool bag that you need to optimize the guide. As we all learned in fellowship, that's really the make or break for your procedure. So a few take-home messages. Planning for adequate guide support starts with your access plan. Again, we do a lot of radial. We do a lot of 7 French radial. I think it's a good tool to keep in your kit. Guide extensions and supportive wires will solve the majority of your guide support issues. And then consider use of advanced techniques such as balloon anchoring. But again, none of these techniques will take away your need for good lesion prep and good PCI, which my partner now is Dr. Kerrigan, is going to go over in terms of complex anatomy.